want to say before I start this. Number one, just because you're a diabetic does not mean you're going to fall victim to what we're talking about today. But because you're diabetic means you are more prone to getting these problems that I have in my talk. All right, so first and foremost, I have noticed with my diabetic population that a lot of people have diabetes, but they have no idea what it is. Now remember, I'm a podiatrist. I do not treat diabetes. I treat the diabetic foot. However, I'm going to give you just an overview of what exactly is going on in your body. So diabetes is the inability of your body to process blood sugar for the use in the body. We need glucose. That's what our brain uses to metabolize things, and diabetics have a hard time using the glucose as needed. With diabetes, your body either doesn't make enough insulin or does not use insulin properly, which allows sugars to build up. So insulin is what brings the glucose into the cells. Diabetes is associated with serious illness, including heart disease, blindness, kidney disease, and lower extremity amputation. Once again, just because you're diabetes does not mean you're going to get these things, but you are statistically more prone to them. Diabetes is also the 7th leading cause of death in the United States, okay? And I really feel like a lot of this is due to the inadequate education. So that's why we're kind of jumping on board to educate you and let you know about it. All right, so the diabetic foot. So we're going to touch on dry skin, calluses, corns. We're going to touch on toenail thickness and deformity. We're going to touch on circulation issues, neuropathy, and deformity that can happen. We're also going to touch on amputation a little bit as well. So why is dry skin scary in the diabetic foot? Well, when you have dry skin, it is almost always benign. When you're diabetic, however, you can go from this to that to that. The last picture is what I don't want to see. The last picture is infection. You can develop a diabetic wound from dry skin, believe it or not. Therefore, when you notice on your feet picture number 1, please seek one of us out. Don't wait until picture number 3. The majority of people wait till picture number 3, and so I'm still here for you, but I don't want to have to take you to surgery. I don't want to have to amputate something. I don't want to have to do this and this and this. I want to prevent this stuff. I want to teach you how to prevent this stuff. All right, so another important thing that I realize people don't understand is the difference between dry skin and athlete's foot, and sometimes it's super, super obvious. Dry skin is related to diabetes due to neuropathy and circulation issues, okay? Now, athlete's foot is an actual fungal infection of the skin, but people with diabetes are more prone to it because of the lack of, you're immunocompromised somewhat. Treatment-wise, we have antifungals, keratolytics, creams versus lotions versus ointments, and we're going to go over that a little bit. Now, once again, we got a gruesome picture, but picture number 1 is athlete's foot. Picture number 2 is athlete's foot. Picture number 3 is athlete's foot. So you can look like you have just benign dry skin, and it is indeed athlete's foot and could turn into picture number 3. They're all treated, these problems are all treated with antifungals, not over-the-counter creams and lotions. All of these should be treated with prescription antifungals. The reason why I say that is a lot of people will go to the store and they will get Lotrimin. That's great. But then they proceed to use it for months. That's not great. It is a true antifungal. It is killing fungus on your body that you actually need a little bit to keep other things like bacteria at bay. If you're overusing it, you're setting yourself up for what we call a superinfection. I have seen it with my own eyes. Patients with cellulitis all the way up to their hip because they were using an antifungal for months. So if you have itchy, scaly, dry skin, please come see me or a healthcare provider that specializes in the foot and ankle. All right, treatment. So like I said, antifungals are used for athlete's foot. All right. Keratolytics. Keratolytics are used for severe dry skin. So the fissuring and the cracking in the heels. Those medications are ammonium lactate or amlactin. That is not showing that. That is the one on the far right, and you can get that at Walmart. It's like $13. It is great. It's useful. Please use it if you have dry, fissured skin. Do not put it in between your toes. Never put lotion in between your toes unless you are directed to do so by a physician, all right? Because of picture number 3, because that can happen. All right. Urea, the bottom middle picture. I actually sell this in my office because insurance doesn't like to pay for it, but it is an excellent, excellent adjunct for severe dry skin and calluses. And then, of course, my favorite over-the-counter regular cream for regular dry skin is Eucerin or Jergens Ultra Healing Lotion. Once again, do not put it in between your toes, please. All right, corns and calluses. So, a buildup of hyperkeratotic tissue caused by excessive friction or pressure, meaning it is almost always caused by shoe gear or walking around barefoot on hard surface floors, all right? And it's because you're rubbing, you're turning, something's rubbing against your foot, and the skin builds up to protect itself, and that's a good thing initially, but then it gets too much, and you can get problems, such as painful calluses and even ulceration. Corn versus callus. So, I used to always tell my patients a corn is just a callus on a toe, which in my mind is still essentially true, but technically you can get corns on the feet as well. So a corn is a thicker, deep lesion. You look at it, it looks really small, and everybody thinks it's a wart. It's not. It's not a wart. Calluses are those thick, broad things. You kind of get it on the inside part of your big toe, underneath your metatarsal heads. Both of them can lead to ulceration. Both of them should be managed properly, especially if they're painful. As a diabetic, all caps, people, do not attempt to treat this at home with acid. I don't care if it's over the counter. And I'm not saying this to scare you, but I'm going to say it anyway. I have cut off many a toes because somebody uses a callus or a corn pad on their toe and they're diabetic. They got an infection, they got osteomyelitis, they were admitted to the hospital, and I had to remove a digit over a callus pad. So do not use them if they're medicated. Now, you can use the little ones that look like a little donut with a little hole in it that don't have the acid in it. That's fine. It just makes it feel better. But do not use the acid unless I instruct you to do so, please. Okay. I'm going to show you kind of the progression of how a callus can turn into a wound, because a lot of people don't understand that. So the first picture comes into my office. I've got this buildup of tissue on my skin. It usually doesn't hurt because of neuropathy, which we'll talk about in a minute. And then I debride it, and I notice at the base of it, it's kind of red. That means the skin's breaking open. Then they don't, but then that patient doesn't come and see me. So they don't come see me, and then we get this. And this is a true diabetic ulcer. This is an open wound that is deep to the skin. The skin is gone. And then that person doesn't come and see me. They're like, well, we're going to wait a few weeks. And then is that. Now, I didn't put in more graphic pictures than I could have. But then there's bone hanging out. And then there's black. And then I have to cut something off. So our goal is when it looks like picture number 1, or even before it gets that bad, it should be evaluated. It doesn't mean I have to see you every week and do something. It just, I can tell you, okay, this is bothering me, this is scary, we need to treat this, or you monitor it at home, we'll watch it, etc. Treatment for calluses and corns. Debridement by a physician. No pocket knives. No razor blades. No, I got in my kitchen drawer and found this thing and it works great. Please, no. Just saying. I'm not that old, but I've been doing this for long enough. Don't do that. Keratolytics, so the urea cream and the ammonium lactate, those are excellent adjuncts. They will not cure this, but they will make it better. They will decrease the chances of skin breakdown. Offloading and accommodated devices. So a lot of people come into my office and they have a callus or a corn, and in their mind they want to cushion it. So they'll build up their shoe, or they'll put like a pad over it. you actually need to do the opposite. So you need to offload it. So instead of putting padding on it, you should put padding around it so that when you step down, you're not putting a lot of pressure there. And then occasionally, surgery is necessary for just a callus. It is very rare. I'm very conservative as a surgeon. All my patients know that. But sometimes you're at a risk of developing a diabetic ulceration, and it gets to the point where the risks of the surgery are way less than the risks of not doing it. So occasionally the deformity causing the callus or corn has to be corrected. So debridement by a physician, keratolytics, urea cream is my favorite. Offloading, so this is padding a corn. This is offloading a corn. So you can have devices made where they cut it out. So if you're stepping down, it's not digging into the ground. And this is an example of offloading the corn. And if you're my patient and you have a callus on the bottom of your foot, I've probably done that. And occasionally surgery. Okay, toenails. So a lot of people ask about toenails. Toenails. So, trimming thickened and malformed toenails can be difficult and even dangerous for a diabetic for obvious reasons. You cut yourself. You cut yourself because it's not like you're trying to hurt yourself, but the toenails are so thick that you're digging and trying to get it really good, and then you end up cutting yourself. Ingrowing toenails. As a diabetic, please do not try to cut those out yourself. Let me do it. I've done a lot of them, I promise. Thick and discolored nails can be associated with a fungal infection or even microtrauma. And the last bullet is very important, and this is just for people in general when you go and see a podiatrist. It is not always fungus. So everybody thinks a thick discolored nail has to be fungus. It does not have to be fungus. And even if it is fungus, when you are a brittle diabetic with problems, we're probably not going to treat that fungus anyway. So keep that in mind when it's in the toenail, okay? Microtrauma, meaning you wore a shoe 20 years ago for a period of a month and it was too small. That can lead to thick toenails, like picture number 1 or 2, all right? Dropping a beam on your toe 50 years ago can lead to a thickened abnormal toenail, like pictures 1 and 2. So just keep that in mind. Like it's honestly, it's usually trauma. It's usually trauma. Treatment. So if it is indeed fungus, antifungals is what we need if we decide we need to treat it. I do topicals rarely because for toenail fungus, they don't work. Cream on your toenail does not work. I'll just tell you that now. Now, lacquers and the polishes and stuff, they have a potential to work, but it's usually only about 15 to 20% effective, which is better than nothing, but it's only about 15 to 20% effective. If you truly want to cure your fungus, if it is curable, you're either going to need a prescription strength topical or you're going to need an oral antifungal, which is a pill. I don't really prescribe the oral antifungals that often because it's a pill and it has side effects, and people forget about that a lot. Regular toenail debridement by your local podiatrist. Now, all of my patients know toenail debridement is one of my least favorite parts of my job, but I don't mind doing it. Just because you're diabetic doesn't mean you qualify for toenail debridement, but if you come, I do a full diabetic exam. If you have the qualifying factors, if I truly believe it is a danger to your health to trim your own toenails, I will 100% trim them for you. It is fine. Softening agents. Once again, those keratolytics, that urea cream, excellent use on toenails. Vicks Vapor Rub, excellent use on toenails. And then regular soaking and moisturizing. A lot of people forget that your toenails are an extension of your skin. So when you put lotion on your feet, you should be lotioning your toenails as well. It just keeps them moisturized. Okay, circulation. How is circulation related to diabetes? Well, diabetes can be associated with poor circulation. How can it be bad or even devastating? And a lot of this is common sense, just so you know. Y'all probably know this. But with decreased blood supply, you can get skin breakdown, leading to chronic wounds, gangrene, and of course amputation. A lot of people complain, they come in, they automatically assume that they have poor circulation because they always say, my feet are always cold. Just because your feet are cold does not mean you have poor circulation. Now, if I can feel your pulse, If you look down and you see hair on your toes, and you see healthy skin, and your toenails are growing and they kind of grow too fast, those are all signs of healthy circulation, and you still may have cold feet, okay? Cold feet actually is more associated with neuropathy and thyroid issues. So keep that in mind. And if you notice that you have a ton of cold, you feel cold all the time, your hands are cold, your feet are cold, it might not be a bad idea to go to your primary care doctor and have your thyroid checked. All right, signs and symptoms of poor circulation. So intermittent claudication. So that's a fancy term for cramping in the calf muscle after periods of walking. Now, for some people, that could be 200 yards. For some people, that could be from your couch to your refrigerator. The shorter the distance, the worse it can be. As far as your disease, the worse it can be. Whenever you walk a certain distance and you feel that Charlie horse type cramp coming on and you have to sit down and you're like, ouch, you need to be evaluated by a healthcare provider because you probably have moderate disease. Rest pain is the scarier of the two. Rest pain is that cramping at night that only has relief if you sit up in bed and hang your feet down. And that's because the gravity is helping the blood come back down to the feet. If you're having to get up and feel like you got to walk it off, that actually might be a little bit different. That might be more of a Charlie horse cramp, which is completely different. But if you have to hang your feet down, if you can't comfortably sleep in a bed because your feet are up, you need to be evaluated by a physician. And then, like I said earlier, diminished hair growth. No hair on your feet is actually not normal. But if you're shaving your legs and you have to shave your toes, that's a good sign, okay? Atrophic skin. So I want you to look at that picture. So atrophic skin is that it looks like it's pulled tight and it's shiny. Those are all signs and symptoms of decreased blood supply. And then skin temperature changes. Going back to what I said, your feet can be cold. It's usually your feet and your leg, and then when you get to the knee, all of a sudden it's warm. Those are signs of circulation issue, okay? All right, these are scary pictures, but this is the bad. So this is the getting there bad. Need to go see a vascular doctor, get something opened up. This is we waited too long. Once again, don't wait. Come and see me. It can start out as something as a black dot on your toe. That black dot on your toe turns into picture number 2. Picture number 2 turns into picture number 3 if I have to do something surgically. This is what we're trying to prevent. My goal in life for my diabetic patients is limb salvage. I do not like cutting things off. Once again, don't wait. Don't wait till it's too late. All right, how to address circulation issues. So when you come to my office, remember I'm a podiatrist, not a vascular surgeon. But what I usually order is what's called an ABI and an arterial ultrasound. And those are just giving us an idea of how bad your circulation actually is. They don't hurt, they're quick, they're simple, they are ordered as an outpatient here at the hospital, and it tells us a lot. If those ABIs or arterial ultrasounds come back abnormal, I usually refer you to a vascular surgeon. Dr. Lumberg is our local vascular surgeon, and he is excellent at what he does. A lot of patients who have true circulation issues have to have some sort of surgical intervention for limb salvage. We don't want to have to remove anything. We don't want tissue death. Whether that's what's called a roto-rooter, where they go in there and they clean it out, whether they stent it or balloon it, or sometimes you need a full bypass. So they actually have to bypass the artery that's clogged up. And of course, everybody that is in this room that is a diabetic should quit smoking. And I know you hear that from everybody, but it's bad. And it makes all the problems with your diabetes worse. So please, quit smoking if you can. All right, neuropathy. Neuropathy is nerve damage associated with increased blood sugar levels, okay? Tingling, burning, numbness, odd sensations. Patients verbalize the feeling of walking on cotton, walking on a pillow, the pad of their foot feels bigger or swollen. Feel like I'm walking on rocks, I feel like I'm walking on needles. Sometimes it can be something as simple as my feet feel cold. Once again, just weird sensations when your feet shouldn't feel cold. Hypersensitivity before the numbness can happen. So a patient feels okay, but then the sheet touches their foot and they're like, oh gosh, this is uncomfortable. That's all signs and symptoms of neuropathy. Treatment. For neuropathy, as far as I know, there is no true cure. So I can't cure you, but I may be able to give you a diagnosis, which actually helps a lot of people mentally. They just feel better to know what it is. And we can also take care of some of those painful symptoms. Oral medications such as gabapentin, Lyrica, and some antidepressants are used for nerve pain. I will recommend only using these medications if it is truly affecting the quality of your life. And what I mean by that is the majority of diabetic nerve pain is at night when you go to bed, and if you're not sleeping, that is affecting the quality of your life. So you need to seek out a physician to have some sort of medication or relief or something. Topical medications. I prescribe topical medications quite a bit. I will be honest, it's a 50-50. I would probably say 50% of patients respond awesome. They use a cream on their feet before they go to bed. They are pain-free throughout the night. Some people, they try it, it does not work for them, but it is always an option if you're just not a pill person. Oral supplements, vitamin B is a big one, and alpha lipoic acid is a big one. Those are over-the-counter medications. Those are great for you. And then, of course, focusing on muscle strengthening and stretching of the lower extremity, because nerves also supply muscles. Muscles that don't work properly lead to deformity and weakness, and keeping that stuff monitored and stretched out and strengthened is really, really good for your health. Deformity. So diabetes can lead to deformity for the reason I just said, usually neuropathy. Hammer toes, flat feet, high arched feet, bunion deformity, and it's usually associated with motor neuropathy. So the motor nerves, the nerves going to the muscles to make them work, just aren't working as well as they should. Okay. So here is a condition I just wanted to touch base on because a lot of people have no idea what it is. It's called Charcot Arthropathy. So Charcot is a deformity that can develop in a diabetic. Now you don't have to be diabetic, but statistically you're diabetic. And what happens is a patient comes to the doctor because they have a painless, red, hot, swollen foot. And the majority of practitioners sadly go, oh my gosh, you have cellulitis. We have to treat you with antibiotics. This is not infection. This is not an infected foot. I'm talking about left picture. This is an abnormal increase in your blood supply and your bones literally start to break. You can't feel it because you are neuropathic and you're walking on it and the bones are just breaking apart. It is very important to figure this out very, very quickly, because when you don't, it ultimately leads to that rocker bottom foot type, and then you get that ulcer because the bone falls down and you're stepping on it all the time. So treatment. The reason why it's so important to catch this soon is because you need immediate casting with non-weight bearing. You cannot walk on that foot. And if you walk on that foot, you almost always develop the deformity. Occasionally surgery is needed. And then eventually, if you get a true deformity, you'll need some sort of accommodative shoe gear or device. The picture on top is the most common. It looks horrible, but believe it or not, it allows these people to function and it decreases your chances of ulceration. And then custom shoes and insoles as well. All right, I'm almost done. Diabetic ulceration. An open sore or wound that occurs in 15% of people with diabetes. Now that doesn't sound like a big number, but that's a big number. 15% of people with diabetes will have an open wound. Ulcerations form due to a combination of neuropathy, circulation issues, deformity, irritation, trauma, and duration of diabetes. The longer you have diabetes, the more likely you are to get an ulceration. 14 to 24% of patients who develop a diabetic ulceration will end up in amputation. I can't say that enough. 24% of people with an ulceration will end up with an amputation. That is another reason not to wait. Treatment. Treatment of any infection. Of course, if it's infected, it's got to be treated with antibiotics. Debridement. Letting me scrape it. Everybody always questions, well, you're scraping it, you're just making it worse. I'm only taking away bad stuff. I'm taking away bad stuff so the good stuff can take over. Offloading it. Don't put a pad on it. Put a pad around it, like the middle picture. It needs to go around. A lot of people want to pad it. That's the worst thing you can do. You're putting more pressure there. Wound care products that you don't have access to, ointments, creams, collagen, silvers, everything that I have access to can speed up the healing process of these wounds. Managing your blood glucose levels. It is vital that your sugars are under control. You can come to me once a week, but if your sugars are crazy high, you're not going to heal. It's not going to happen. And it's just that blood glucose itself is delaying it. And then once again, quit smoking, please. All right, amputation. In the United States, greater than 60% of non-traumatic lower extremity amputations, so non-traumatic, so you didn't get it cut off in a machine, is due to diabetes. So 60%. About 65% are done annually, just in the United States. Increased risks include males, smoking, high blood pressure, diabetic retinopathy, if your diabetes is affecting your eyes, increased hemoglobin A1C, very important number to know and to remember for us practitioners that are treating you, are all associated with the risk of lower extremity amputation. When to see a podiatrist? At minimum, I should see you at least once a year. You need a diabetic foot check. Even if your sugars are 100 every day and you have no foot issue, you should still be seen once a year. If any increased risk factors such as uncontrolled blood glucose, circulation issue, or severe deformity, you may need to see me more often. And then immediately, if any skin breakdown is noted, if it's red and hot, if there's drainage on your sock, if there's a crack, anything like that, immediate. Not 2 days, not 3 weeks, immediate. Other vital physician consults. These are people that are your best friends. Number one is your primary care doctor. And if you feel like your primary care doctor is not adequately treating you, teaching you, telling you about your disease, then find a new one. Vascular surgeon. Now that's my cohort. The vascular surgeon helps me do my job. And then an endocrinologist. An endocrinologist is a physician that specializes in diabetes, and sometimes it is necessary. Sometimes the patient has perfect diet, takes their insulin like they should, exercises, and their sugars are still sky high, and sometimes it just takes more, and an endocrinologist can offer that. And I'm done.